So at this point in the symposium, we'd like to turn it over to the audience to see if there are any specific questions regarding closed pulse irrigation that we can answer for you.
In the case studies presented, was CPI used alone or in conjunction with other modalities such as enzymatic debriders or e-stim?
In most of the cases, it was used as a monotherapy. In 2 of the cases, there was a negative pressure device used in conjunction with the CPI, but it's typically used as a monotherapy.
Why is the open or suction pulse lavage unsafe?
The open pulse lavage has been found to be unsafe because of contamination of infectious materials. At 15 psi, irrigating an infected wound, there's disbursement of fluid that has bacteria and infectious particles on it. And the study at Johns Hopkins from JAMA in 2004 demonstrated that this dissemination of infectious material can have drastic consequences.
Is the CPI system better than traditional sharp scalpel debridement?
Well, in terms of sharp debridement, you're always going to be making the wound bigger. The advantage of CPI over sharp debridement is that it selectively hydromechanically debrides the bacteria and the biofilm while preserving the underlying healthy tissue. That's the real difference between sharp debridement and CPI.
Is the CPI system less painful than an open or a pulse suction lavage?
Yes, the CPI system offers 2 specific advantages. It is a no-touch, no-suction technique. Therefore, there's nothing in contact with the patient that would cause pain or discomfort. So we found that it is much better tolerated by patients and really decreases the pain associated with traditional pulse lavage.
How effective is CPI on tunneled wounds?
Tunneled wounds are a challenge. There are multiple tips available. The normal tip is a wide tip that is fairly short and does not penetrate well into the tunneled wounds. However, there is a skinny tip that is longer, thinner, and better suited to enter into the tunneled wounds and thoroughly irrigate those specific wounds.
Is the CPI system safety proven?
Yes, the study at Wake Forest demonstrated that there was a statistically significant difference with regard to the dissemination of infectious material, and that with the CPI system, that dissemination was effectively shut down. So it is much safer than traditional pulse lavage.
When using the CPI system, is there a cutoff period when you should discontinue treatment?
We recommend that the therapist perform CPI for at least 21 days. We've seen that at the 21-day period, there is a significant increase in granulation tissue because of the removal of the biofilm and of the bacteria. So when the therapist sees that progress, that's when we feel comfortable about having options for the wound. You can continue the CPI until reepithelialization occurs, or at that point, after the 21-day period, the patient may be a candidate for a surgical procedure like a skin graft.
How is the CPI system different than the open or suction pulse lavage?
CPI brings containment to that therapy. Therefore, you are preventing the dissemination of infectious material by using the CPI system. Open pulse lavage does not provide that level of safety. Open pulse lavage also uses suction and has contact. Therefore, it is more painful than CPI. So CPI brings containment and makes the procedure better tolerated by the patients because it's less painful.
Okay, I have several questions. Do you generally discontinue use of the CPI when you have hypergranulation? And also you mentioned INR greater than 2 being a contraindication. Are there any other contraindications to using the CPI?
Well, I'll answer your first question first. When you have an area of hypergranulation, you would not want to continue treating that specific area of the wound. You would want to address the hypergranulation tissue. But in the other parts of the wound that may not be hypergranulating, you would continue to focus your CPI on that area of the wound. With regard to contraindications, we spoke about INR greater than 2. But any coagulopathy where a patient is prone to bleeding, that is a contraindication to CPI. For example, sometimes dialysis patients on the day of their dialysis, because of the heparin that is given during that treatment, is a contraindication to that CPI during that day. So really any situation where we have coagulopathies is a contraindication to CPI.
Okay, and my next question is, since you bill for CPI under sharp debridement, and sharp debridement is only justified when necrotic tissue is present, and I noticed in several of the case studies that you were still using CPI with a full bed of granulation tissue, how are you justifying using CPI when there's no necrotic tissue?
Because even though you can't see the biofilm with your naked eye, it is still there. And if you allow the biofilm greater than 24 hours to reform, you will start to take steps back in your wound healing. By doing a daily irrigation with CPI, you're essentially disallowing the biofilm to reform and promoting healthy granulation. So that process really justifies the daily treatments with CPI.
Is 3 liters of normal saline standard for all wound sizes? And if not, can you use the leftover saline on the next treatment?
We recommend at least 1 liter for an irrigation. In smaller wounds, 1 liter is recommended for a CPI treatment. In larger wounds, 3 liters are recommended. We typically believe in a single use. That is, if a bag is used for that patient, it should be completely used during that treatment and should not be saved for later treatments at a later date.
How is CPI different from the wound vac or other wound treatments?
CPI offers selective hydromechanical debridement. The wound vac is a negative pressure device. It does not debride the wound. CPI offers this selective hydromechanical debridement that effectively cleanses the wound by removing biofilm, by removing bacteria, and allowing the healing to occur at an accelerated rate.